now I will discuss the disease hypothyroidism together with its definition, pathophysiology, etiology and risk factors, clinical manifestations or signs and symptoms, the diagnostic procedure, medical management, and the nursing management. So first, let me define what is the disease hypothyroidism. So it is a condition where the thyroid gland does not produce enough hormones. These hormones control metabolism or how the body uses energy. So when they are low, the body becomes slow, affecting the energy, heart rate, and the digestion of the patient. Now, let's move on to the next part of the table, which is the etiology or the risk factors. So for the causes, it includes some autoimmune diseases like Hashimoto's thyroiditis, where the body attacks the thyroid. Also, a thyroid surgery that removes part or all of the gland. Some causes may also to the radiation therapy that damages thyroid cell and medication that interfere with hormone production. Iodine imbalance, if it's too little or too much, affects hormone synthesis. Also, a pituitary disorder. While in the risk factors naman, first we have the female sex. So basically, it's more common in women yung pagkakaroon ng ganitong disease. And older age, family history of thyroid disease, and presence of other autoimmune conditions. Also, for the pregnancy or postpartum hormonal changes. Now, for the next part, let's move on to clinical manifestations or the signs and symptoms. So it may include fatigue and weakness. Our patient may experience sudden weight gain, cold intolerance, dry or rough skin, hair thinning or hair loss, constipation, and bradycardia. For other symptoms, the patient may also experience depression or slow thinking, puffy face, hoarse voice, or the swelling of the vocal cords, menstrual problem due to hormonal imbalance, muscle cramps and stiffness, and delayed reflexes or mabagal yung nerve response nung bata. Now for the disease diagnostic procedure or test. First, we have the TSH test, or high TSH means the body is trying to stimulate a weak thyroid. T4 test, low T4 confirms low hormone production. T3 test, sometimes low but it's less reliable. Thyroid antibody test, so it detects autoimmune causes like Hashimoto's thyroiditis. Lipid profile, it may show high cholesterol due to slow metabolism. CBC, or it can show anemia, low or high red blood cells. Then we also have the ultrasound, so it checks size or the abnormalities of the thyroid, and radioactive iodine uptake, so it measures how well the thyroid absorbs iodine. For the next part, we also have the medical management or the treatment. So the main treatment is the levothyroxine, a synthetic hormone that replaces T4. So it restores normal metabolism and body functions. So it's taken daily, usually in the morning on an empty stomach for better absorption. And it's important to regular monitor of the THS level if needed and adjust the dose. Underlying causes are also managed. Symptoms such as constipation or high cholesterol are treated as needed. And lastly, for the last part of the table is the nursing management. First, we must monitor vital signs, especially the heart rate and the temperature of the child. Observe for improvement or worsening of symptoms. Administer medication correctly and consistently. Then monitor laboratory results such as THS, T4 levels, encourage a balanced diet to support metabolism, help manage constipation, keep the child warm due to cold intolerance, and promote rest but also gradual activity to prevent fatigue. Also, we must educate the mother about a lifelong medication and adherence of a child. And lastly, watch for complication and report abnormalities early.
And now we will discuss the pathophysiology of hypothyroidism. So hypothyroidism is a condition where the thyroid gland does not produce enough thyroid hormones, mainly the T3 and the T4. So these hormones are important because they regulate the body's metabolism, energy production, and the overall organ function. And so to understand the pathophysiology, we first need to look at how the thyroid is normally regulated. So the process starts in hypothalamus, which releases thyrotropin releasing hormone or TRH, and this stimulates pituitary gland to release thyroid stimulating hormone or TSH. Then TSH acts on the thyroid gland to produce T3 and T4. And when the hormone levels are enough, a negative feedback mechanism signals the brain to stop producing T3 or TRH and TSH. In hypothyroidism, this process is disrupted. So the most common cause is the primary hypothyroidism, where the problem is in the thyroid gland itself. One example is the autoimmune destruction, like Hashimoto's thyroiditis, where the immune system attacks the thyroid tissue. Because of this damage, the gland cannot produce enough T3 and T4. As thyroid hormone level decrease, the pituitary gland to try to compensate by increasing that thyroid stimulating hormone production, and that's why patients with primary hypothyroidism usually have high TSH but low in T3 and T4. Due to low thyroid hormones, the body's metabolic processes slow down. This leads to decreased oxygen consumption, reduced heat production, and slower cellular activity. As a result, patients may experience symptoms like fatigue, weight gain, intolerance, constipation, dry skin, and slow heart rate. And in some cases, hypothyroidism can also be secondary, where the pituitary gland fails to produce enough TSH, or tertiary, where the hypothalamus does not release enough TRH. In these cases, both TSH and thyroid hormone levels are low. Another important effect is the accumulation of substances like glycosaminoglycans in the tissues, which leads to mycedema and characterized by non-pitting edema, especially the face and extremities. So in summary, hypothyroidism occurs when there's an insufficient production of thyroid hormone, leading to generalized slowing of metabolic processes. So the condition may originate from the thyroid gland itself or from problems in the hypothalamus or pituitary gland.
So now I will be discussing the drug levothyroxine. So levothyroxine is known by the brand name Synthroid and Eltroxin. So its generic name is levothyroxine and it belongs to the drug class called thyroid hormone replacement. So this medication can be administered through oral route, which is the most common, and intravenous route, which is only used in emergency situations. So levothyroxine acts on the endocrine system, specifically the thyroid gland. Levothyroxine is prescribed to treat pediatric hypothyroidism, whether it is congenital or acquired later in childhood. The medication helps restore normal thyroid hormone levels, which are essential for proper growth, brain development, metabolism, and overall physical development in children. Without replacement therapy, hypothyroidism can lead to delayed growth, developmental issues, and metabolic problems. Mechanism of action: levothyroxine is a synthetic form of the thyroid hormone T4. Once in the body, it is converted into the active hormone T3, and the T3 binds to the thyroid hormone receptors in cells. stimulating metabolism, increasing oxygen consumption, promoting protein synthesis, and supporting normal growth and development. Essentially, levothyroxine replaces the deficient hormone in hypothyroid patients, helping their bodies function normally. For the side effects, common mild side effects of levothyroxine include headache, insomnia, tremors, and palpitations. For the adverse effects, these usually occur in cases of overdose or excessive dosing. This may include tachycardia, arrhythmias, hypertension, angina, and myocardial ischemia. So patients may also experience symptoms of hyperthyroidism such as weight loss, diarrhea, and heat intolerance. With long-term use, there is also an increased risk of osteoporosis. For client education, patients should understand that levothyroxine is usually a lifelong therapy and not a cure. It should be taken on an empty stomach, ideally 30 to 60 minutes before breakfast to ensure proper absorption. Patients should avoid taking calcium, iron, or antacids within 4 hours of the medication, as this can interfere with absorption. They should also be instructed to report symptoms such as chest pain, palpitations, or excessive sweating, which may indicate over-medication. And regular monitoring of TSH and T4 levels is important for proper dose adjustment, and patients should keep a list of their medication to prevent possible drug interactions. And lastly, for nursing considerations, before administering the drug, the nurse must verify the correct drug dose, and route to ensure patient safety. Baseline assessment should include vital signs such as heart rate, blood pressure, and temperature. The nurse should also assess for any history of cardiac disease, since levothyroxine can increase metabolic demand and may trigger arrhythmias. Baseline weight and thyroid function test uh, including TSH, T3, and T4 should also be recorded. During administration, levothyroxine should be given on an empty stomach with water to promote optimal absorption. Tablets should not be crushed or chewed unless specifically ordered. The nurse should also observe for any immediate adverse reactions, although these are rare. After administration, continuous monitoring is essential. The nurse should watch for signs of hyperthyroidism such as palpitation, tremors, insomnia, and excessive sweating. Vital signs and overall patient condition should be reassessed regularly. Follow-up laboratory tests, especially TSH and TFR, should be monitored to guide dose adjustment. Proper documentation of the patient response, adherence to therapy, and any adverse effects is also an important responsibility. So that concludes the drug study on levothyroxine.
And now I'm going to explain the NCP of the patient who is diagnosed with hypothyroidism. So first assessment, for subjective data, the mother stated that palaging napapagod ang anak ko. Lagi siyang inaantok at parang mabagal kumilos. Dagdag pa niya, napansin din ang poor appetite, constipation at pagiging malamigin ng bata. So for objective data, na-observe natin na ang bata ay lethargic or matamlay, ang mabagal kumilos, may dry at coarse skin. Meron din siyang puffy face or myxedema. And constipated din ang bata, may cold intolerance at delayed din yung response niya. Or meron siyang poor concentration. Napansin din ang weight gain kahit mahina kumain. And then, napansin din sa objective data na ang bata is bradycardia. So, for vital signs naman, the heart rate is 60 beats per minute, which is bradycardia nga po. This isn't the normal for the sa mga bata, hindi po siya normal. So sa blood pressure po niya 90/60, while the respiratory rate is 18. The temp is 36.2 degrees Celsius, and for the laboratory results, meron siyang decreased T3 and T4, and mayroon siyang mataas na TSH, which is the thyroid stimulating hormone. And meron din siyang possible mild anemia, possible low blood glucose. So overall, these findings indicate a low metabolic state which is consistent with hypothyroidism. So now let's proceed to diagnosis. So based on the data gathered, our nursing diagnosis is decreased cardiac output related to decreased metabolic rate and bradycardia, secondary to hypothyroidism as evidenced by bradycardia, fatigue, hypotension, cold intolerance, and lethargy. So for simple clarification po, ibig sabihin nito dahil mabagal ang metabolism ng katawan, bumabagal din po ang trabaho ng puso kaya naapektuhan po ang pag-circulate ng ang dugo ni patient. So, for planning naman po, syempre kailangan natin ng response sa condition ni patient. So, meron po tayong goals. For our goals, we divided it into short-term and long-term. For short-term po, yung goals natin within 4 hours of nursing care. First, the child will maintain heart rate near normal limits. The child will show increased alertness and participate in simple activities. And the caregiver will demonstrate understanding of thyroid hormone therapy and proper care. So, sa long-term goals naman po natin, ito po yung within 8 hours, the child's T3 and T4 levels will trend toward normal. So, magiging normal po siya. And vital signs will stabilize. Yung kanina po, bradycardia na nagkakaroon po ng improvement. And then, energy level will improve din po. And bowel movement will improve to occur. So now let's proceed to interventions. So for independent nursing interventions, monitor po natin yung vital signs every 1 to 2 hours for early detection of bradycardia po and worsening condition. We also going to assess level of consciousness and activity tolerance dahil po ang hypothyroidism ay nagdudulot ng pagiging matamlay ng bata or ng patient and provide a warm environment to manage cold intolerance. So, i-encourage rin po natin yung rest with gradual activity para maiwasan ng fatigue. So, i-monitor din po natin yung bowel movements dahil common sa hypothyroidism ang constipation, while also encourage high-fiber diet and adequate fluid intake to improve bowel function. And i-monitor po natin yung weight niya regularly to detect fluid retention. So, dito rin po i-educate natin si caregivers on medication adherence para po maiwasan natin yung complications. For dependent nursing interventions naman po, we're going to administer thyroid hormone replacement such as levothyroxine to replace deficient hormones and normalize metabolism. So, next po, i-monitor natin yung laboratory values niya, yung T3, T4, and yung TSH to evaluate effectiveness of the treatment. Also, we're going to administer stool softeners if prescribed po para ma-relieve yung constipation. And also, i-monitor po natin yung blood glucose if indicated dahil pwede pong bumaba ang blood sugar ni patient. And if magko-collaborate po tayo sa pediatric and endocrinologist for specialized management. So, for collaborative interventions naman po, we're going to collaborate with dietitian for a balanced diet, high-fiber diet, para po masuportahan natin yung metabolism and digestion ni patient. And also, we're going to educate family on signs of complications such as severe lethargy and hypothermia. And importante po ito dahil ang family po ang nagbabantay sa bata, so dapat alam po nila yung mga signs para if ever man na magkaroon ng complications is maagapan kaagad. So for evaluation naman po, for the short-term evaluation, after 4 hours of nursing care, the patient maintained improved heart rate nearing normal limits and became more alert and participated in simple activities. And also, the caregiver demonstrated understanding of proper care po. And for long-term evaluation, after 8 hours, the patient's vital signs stabilized, energy level improved, and bowel movement was achieved. And the caregiver continued to demonstrate understanding of management, including medication, nutrition, and lifestyle modifications. So that's conclude the NCP of the patient who is diagnosed with hypothyroidism.
Pag-usapan naman natin ang electrolyte imbalance. So, electrolyte imbalance is a condition where the levels of important minerals in the body katulad ng sodium and potassium become too high or too low. So itong mga electrolytes na to is kailangan ng katawan natin to functions katulad ng muscle movement, nerve signals, and fluid balance at heart function. So itong condition na to is usually nangyayari when there is a problem with the body's fluid balance katulad ng dehydration, too much fluid intake, vomiting, diarrhea, kidney problems, or the use of certain medications like diuretics. When the body is not able to regulate fluids and electrolytes properly, their levels become abnormal. So ito naglilid siya sa mga symptoms katulad ng weakness and muscle cramps, and in severe cases, pwede siyang mag-cause ng seizures, irregular heartbeat, or coma. So, ang two common types ng electrolyte imbalance are hyponatremia and hyperkalemia. Ang hyponatremia is a condition where sodium levels in the blood are too low, causing water to move into the cells and leading to swelling, especially in the brain, which can result in neurological symptoms. Ang hyperkalemia naman is a condition where yung potassium levels in the blood are high, which can affect muscle function and interfere with the normal rhythm of the heart, and may lead to serious or life-threatening complications. So now, mag-focus muna tayo sa hyponatremia. Ang hyponatremia is nangyayari when the sodium level in the blood drops below normal. So either dahil there is too much water dilutes it or because sodium is lost from the body. Excessive water intake such as psychogenic polydipsia can overwhelm the body's ability to maintain normal sodium levels. Hormonal imbalance, particularly SIAD, can cause the body to retain water, further lowering sodium concentration. Chronic medical conditions katulad din ng mga heart failure, liver cirrhosis, and nephrotic syndrome are also linked sa hyponatremia because they affect fluid balance. Sodium loss can occur through vomiting, diarrhea, certain diuretics, or adrenal insufficiency, all of which remove sodium from the body. Ang clinical manifestation and signs and symptoms naman ng hyponatremia is nagbe-vary depending on how low sodium is. Mild hyponatremia may cause nausea, headache, and fatigue as the sodium level continues to drop. Confusion, muscle cramps, and generalized weakness may appear. In severe cases, the brain can swell due to fluid shifts, leading to dangerous neurological complications such as seizure, coma, or even respiratory arrest. Diagnostic procedures for hyponatremia focus on confirming low sodium levels and identifying the underlying cause. Serum sodium measurement is the primary test used to confirm hyponatremia, with values less than 135 milliequivalent per liter indicating a low sodium level. This also helps determine the severity of the condition. Serum osmolality is assessed to evaluate the concentration of solutes in the blood and to classify the type of hyponatremia, which is essential in guiding appropriate management. Next is urine sodium and osmolality are also evaluated to determine how the kidneys are regulating sodium and water balance, helping differentiate whether the cause is renal or non-renal. Additionally, kidney and liver function tests are performed to identify possible underlying conditions katulad ng renal failure or liver disease that may contribute to the electrolyte imbalance. The medical management of hyponatremia aims to correct sodium levels and address fluid imbalance. Fluid restriction is commonly implemented, especially cases of delusional hyponatremia, to reduce excess water in the body. So, ang delusional hyponatremia is a type of low sodium in the blood that happens not because sodium is lost, but because there's too much water in the body. In severe or symptomatic cases, hypertonic saline solutions such as 3% sodium chloride may be administered carefully to increase serum sodium levels. Rapid correction is avoided to prevent neurological complications. Management also includes treating the underlying cause such as discontinuing diuretics, monitoring syndrome of inappropriate antidiuretic hormone secretion, or correcting adrenal insufficiency. Nursing management of hyponatremia focuses on monitoring neurological status and maintaining fluid balance. The nurse should closely monitor the patient's level of consciousness and observe for signs of confusion, lethargy, or seizures. Vital signs should be assessed regularly to detect any changes in the patient's condition. Strict intake and output monitoring is essential to evaluate fluid balance and the effectiveness of treatment. Fluid restriction should be implemented as prescribed, and the patient should be educated on its importance. Sodium replacement therapy should be administered as ordered, with careful monitoring for adverse effects. Seizure precaution must also be initiated in patients at risk, including ensuring a safe environment and availability of emergency equipment. Now, pag-usapan naman natin ang hyperkalemia. So, ang hyperkalemia is nangyayari siya when potassium levels in the blood rise above normal. Usually, dahil ang kidneys hindi na siya makapag-excrete ng enough potassium. So, ito is commonly seen in renal failure where kidney function is impaired. High potassium intake from diet or supplements can also contribute. So, some medications katulad ng ACE inhibitors, ARBs, and potassium-sparing diuretics can increase potassium levels. Additionally, conditions that cause rapid tissue breakdown such as trauma, burns, rhabdomyolysis release potassium into the bloodstream, raising its level. Hyperkalemia mainly affects muscles and the heart. Early signs include muscle weakness, fatigue, and tingling sensations or yung tinatawag nating paresthesia. Gastrointestinal symptoms such as nausea and diarrhea can also occur. The most serious effects are cardiac. ECG changes like peak T waves, widen QRS complex, and abnormal heart rhythms may develop. Severe hyperkalemia can progress to life-threatening cardiac arrest if not treated promptly. The diagnostic procedures for hyperkalemia are aimed to confirming elevated potassium levels and assessing its effect on cardiac function. So, serum potassium measurement is the primary diagnostic test, which levels greater than 5.0 milliequivalent per liter indicating hyperkalemia. So, this also helps determine the severity of the condition. Next is electrocardiogram or ECG is a critical diagnostic tool as hyperkalemia can significantly affect cardiac conduction. Typical findings may include peak T waves, widened QRS complexes, and arrhythmias. Next is kidney function tests, including blood urea nitrogen and creatinine, are also performed to assess the kidney's ability to excrete potassium. Next, arterial blood gas analysis may also be done to detect acid-base imbalances, particularly metabolic acidosis, which can worsen hyperkalemia. The medical management of hyperkalemia is focused on stabilizing cardiac function and lowering serum potassium levels. Intravenous calcium gluconate is administered to stabilize the cardiac membrane and reduce the risk of life-threatening arrhythmias. Insulin combined with glucose is given to promote the movement of potassium from the extracellular space back into the cells, thereby lowering serum potassium levels. Other medications, katulad ng sodium bicarbonate or beta agonists, may also be used to shift potassium into the cells. To eliminate excess potassium from the body, diuretics or dialysis may be required, particularly in severe cases or in a patient with renal failure. It is also important to discontinue potassium supplements and medication that may contribute to increased potassium levels. So, nursing management on hyperkalemia prioritize cardiac monitoring and prevention of complication. So, continuous ECG monitoring is essential to detect early signs of cardiac arrhythmias. The nurse should assess muscle strength and neurological status as hyperkalemia can cause muscle weakness and paralysis. Strict intake and output monitoring is necessary to evaluate kidney function and potassium excretion. Medication prescribed to lower potassium levels such as calcium gluconate and insulin with glucose should be administered promptly and monitored closely. Patient education is also important, particularly in advising the patient to avoid foods with high in potassium and to adhere to prescribed treatment. Patient education is also important, particularly in advising the patient to avoid high potassium. Patient education is also important. Patient education is also important, particularly in advising the patient to avoid foods high in potassium and to adhere. Patient education is also important, particularly in advising the patient to avoid foods high in potassium and to adhere to prescribed treatments.
Now I'm going to explain the pathophysiology of hyponatremia. So first, what is hyponatremia? So this is a condition kung saan bumababa po ang sodium level ng dugo below 135 milliequivalents per liter. And importante po ang sodium kasi siyang tumutulong sa fluid balance, nerves at muscle function natin. Maraming pwedeng dahilan po nito like sobrang pag-inom ng tubig, pagsusuka at pagtatae, certain medications or paggamit ng hypotonic IV fluids. May mga cases din na hindi natin nakokontrol like sa infants, kidney problems, hormonal issues like SIAD or severe infections. So, ngayon, paano po nangyayari ang hyponatremia? Kapag mababa ang sodium, nagiging diluted ang dugo. So, bumababa ang plasma osmolality natin. Ibig sabihin, mas marami ng tubig kaysa sa sodium sa bloodstream po natin. Dahil dito, papasok ang tubig sa loob ng cells from outside kasi sinusundan ng tubig kung saan mas concentrated. Ngayon, the problem is, nagkakaroon ng swelling ang cells. The most critical is yung dito is yung brain kasi nasa loob siya ng skull at hindi siya makaka-expand. So kapag nag-swell ang brain cells, nagkakaroon ng cerebral edema or brain swelling. As a result, tumataas ang pressure sa loob ng head kaya lumalabas yung mga symptoms like the headache, vomiting, and confusion. Kapag hindi ito naagapan, pwede itong lumala into seizures, pagbaba ng consciousness, hanggang maging coma po siya. In severe cases, pwede itong mag-lead sa brain herniation, respiratory arrest, cardiac arrest, and eventually death. Sa symptoms naman, usually nagsisimula siya sa mild headache, nausea at panghihina. Then nagiging more serious like confusion and seizures. May tatlong types din ito, the hypovolemic kung saan mas maraming sodium ang nawawala, and yung euvolemic na masasayad, at hypervolemic kung saan sobra ang tubig ng katawan kaya nadidilute ang sodium like sa heart or kidney failure. So, to confirm naman, ginagawa ang lab test like serum sodium osmolality, urine test, at kidney hormone test para malaman yung exact cause nito.
Now let's talk about the pathophysiology of hyperkalemia. So hyperkalemia is defined as a serum potassium level greater than 5.0 MEq per liter. So potassium is mainly an intracellular electrolyte. So meaning most of it is found inside the cell while the only amount is in the bloodstream. So normally, potassium balance is maintained by our kidneys, which excrete the excess potassium, and by the movement of potassium between the intracellular and extracellular spaces. So in hyperkalemia, this balance is disrupted due to three main mechanisms. So first is decreased potassium excretion. So this commonly occurs in conditions like renal failure, where the kidneys are unable to remove the excess potassium from the body. So it can also happen when there is a reduced aldosterone or a hormone that promotes a potassium excretion. So second is the shift of potassium from inside the cell to the bloodstream. So this can occur in acidosis, where the hydrogen ion enters the cell and the potassium moves out to maintain balance. It can also happen in cases of tissue breakdown such as burns, trauma, or hemolysis. And the third is the excess potassium intake. Although this is less common unless the kidney function is impaired, the increased potassium in the blood affects the electrical activity of the cell, especially in the heart. The potassium level plays a key role in maintaining the resting membrane potential. When the potassium level are high, the resting membrane potential becomes less negative, making the cell more accessible at first, but eventually leading to impaired condition. This can also result in serious cardiac effects such as arrhythmias. Common ECG changes includes the peak T wave, widened QRS complex, and a severe case ventricular fibrillation or cardiac arrest. So in summary, hyperkalemia occurs when there is an impaired excretion, increase the release of potassium from cells, or excessive intake, leading to dangerous effect on cardiac and neuromuscular function. And for the drug study of hyponatremia, we have your brand name Samska, generic name tolvaptan, and prefix suffix vaptan, class vasopressin receptor antagonist. So it is so the route of administration is IV. So indication used to treat hyponatremia by restoring normal sodium level in the blood and preventing neurologic complication. The mechanism of action, sodium chloride restores sodium and draws out water. So while atolvaptan blocks the ADH to remove the water and raise the blood sodium. And for the side effects, thirst. It is caused by increased water loss. Dry mouth, result of dehydration from fluid removal. Frequent urination because kidneys excrete excess water to raise sodium level. Adverse effects, we have your rapid sodium correction, hypernatremia, dehydration, hypotension, liver toxicity with tolvaptan, and seizures. And contraindication and precautions, we have your severe dehydration, may worsen fluid and electrolyte imbalance, anuria or urine output, medication ineffective and risky, hypersensitivity, allergic reaction to the drug, and caution in renal or liver disease, risk of toxicity and worsening condition. So, client education, explain gradual correction to prevent complications, report symptoms like confusion, weakness, or seizures immediately, follow fluid restriction as prescribed, do not adjust fluid intake in your own, monitor electrolyte regularly as advised by the nurse or by the doctor, and consideration intervention before administration, check serum sodium level, assess neurological status, level of consciousness, seizures, monitor fluid balance, intake and outtake. During administration, administer IV fluids slowly and carefully, monitor vital signs frequently, and for the after administration, we need to recheck the sodium levels regularly, monitor for signs of overreaction such as confusion, speech changes, and assess hydration status. Observe for absent adverse reaction such as headache, fatigue, and hypotension. And for last is document the patient's response and intervention.
So now let's talk about the drug study on calcium gluconate. Calcium gluconate is known by the brand name calgluconate. Its generic name is calcium gluconate and it belongs to the class of electrolyte or mineral supplements. It is administered via the intravenous route and it primarily acts on the cardiovascular and muscular system. For its indication, calcium gluconate is mainly used in patients with hyperkalemia para ma-stabilize yung cardiac membrane nila. It helps prevent life-threatening arrhythmias caused by elevated potassium levels in the blood. For its mechanism of action, ang calcium gluconate works by restoring the normal threshold potential of myocardial cell. This stabilizes the cardiac membrane and reduces the risk of arrhythmias. So, it is important na i-note natin na ang calcium gluconate is hindi niya pinapababa yung potassium levels. Ang primary role nito is para maprotektahan yung heart first. While yung other treatments katulad ng insulin with dextrose or dialysis are ginagamit para ma-reduce yung potassium levels afterwards. Ang side effects naman nito, yung mga patient is pwedeng makapag-experience ng flushing or a feeling of warmth, temporary hypotension, and discomfort at the IV injection site. For adverse effects, this may occur when the drug is given too rapidly or in high doses. This include hypercalcemia, arrhythmias, and tissue necrosis if extravasation occurs. For contraindications and precautions, calcium gluconate should be avoided or used cautiously in patients with hypercalcemia as it can worsen the condition. It should also be used carefully sa mga patients with digitalis or digoxin toxicity since it may trigger dangerous arrhythmias. Sa mga patient naman with renal impairment, there is an increased risk of calcium accumulation, so monitoring is necessary. Additionally, patients with cardiac conduction disorders require close monitoring due to increased sensitivity to calcium effect on the heart. So in summary, ang calcium gluconate is not automatically safe sa lahat ng pasyente at ito is ginagamit depende sa on the patient's calcium levels, cardiac status, and kidney function. For client education, patients and their families should understand that this drug protects the heart but does not remove excess potassium, so additional treatments may still be needed. They should be informed that improvement in heart rhythm is usually rapid. Patients should also be instructed to report any pain, swelling, or redness at the IV site which may indicate complications. Encouraging patients to ask questions and participate in monitoring is also important. And lastly, for nursing responsibilities, before administration, the nurse should verify the correct drug, dose, and IV route, assess baseline vital signs, obtain an ECG, and check serum potassium and calcium levels. During administration, calcium gluconate should be given slowly over 5 to 10 minutes while maintaining continuous cardiac monitoring. The nurse should also ensure that there is no extravasation as leakage can cause tissue damage. And after administration, the nurse should monitor vital signs and cardiac rhythm and observe for signs of hypercalcemia such as nausea, vomiting, or bradycardia. Proper documentation of the patient response and the adverse effect is essential. So that concludes the drug study on calcium gluconate.
Now, let's move on to the nursing care plan of the disease hyponatremia. First, we have the assessment. And for the subjective part, the mother stated that the child feels dizzy, restless, and nauseous. So meaning, the child is not feeling well and showing some early signs of imbalance in the body. While in the objective data naman, I observed that the child has a low sodium, low blood pressure, slightly fast heart rate, drowsy and confused, experiencing muscle cramps and weakness, experiencing nausea and vomiting, has a mild swelling, and has a low urine output. Meaning the body salt or the sodium level is low, which affects the brain, muscle, and the circulation of the child. Now, for the diagnosis part of the nursing care plan, it's risk for the decreased cardiac output related to low sodium or the hyponatremia. Meaning, because sodium is low, the heart may not pump blood effectively, which can affect oxygen delivery to the body. Now for the planning, we have the short-term goal. Within 1 to 2 hours, vital signs became stable, dizziness and confusion decrease. And for the long-term goal naman, for about 5 to 8 hours, sodium returns to normal, no confusion or neurological problems. So in here, the child should fully recover and have normal sodium levels. Next is for the intervention. We have the independent part wherein the nurses can do without the doctor's order. So monitor vital signs and consciousness, check symptoms such as vomiting, confusion, and cramps, teach mother about proper fluid and salt intake. Next is for the dependent part wherein with the doctor's order. So give sodium, or it should be oral or IV fluid. Give medications like diuretics if needed. Then monitor lab results like sodium and the electrolyte. And for the last part is the evaluation. Let's see, dito malalaman natin kung nag-work yung treatment. For the short term, child is less dizzy and nauseous. Vital signs became more stable and the child became more alert. And for the long term, sodium level becomes normal, no confusion or weakness, and no signs of imbalance.
Now I'm going to explain the NCP of the patient who is diagnosed with hyperkalemia. So starting with assessment, so subjective data, the mother stated that nahihirapan huminga ang anak ko, masakit ang tiyan niya at parang nanghina siya at madali siyang mapagod. And for the objective data, na-observe natin na ang bata is lethargic or matamlay. Mahina ang muscle tone, may abdominal cramps, may nausea at occasional vomiting. Meron ding irregular pulse, may muscle twitchings, at mabagal kumilos. Sa ECG naman, nakita natin peak ang T-waves, which is classic sign of hyperkalemia. So, for vital signs, ang heart rate niya is 50 beats per minute, which is bradycardia. Blood pressure is 90/60, respiratory rate is 20, temperature is 36.5 degrees Celsius. And for the laboratory results naman, serum potassium niya is 6.5 millimoles per liter, which is mataas. Sa sodium is 136 millimoles per liter, and the creatinine is slightly elevated, suggesting possible kidney involvement. So additional lang po, these findings indicate electrolyte imbalance. Specifically, mataas ang potassium level, which can affect the muscles and the heart. So for diagnosis, based on the data gathered, our nursing diagnosis is decreased cardiac output related to electrolyte imbalance or hyperkalemia, as evidenced by bradycardia, irregular pulse, hypotension, peak T waves, lethargy, and muscle weakness. So, to simplify, ibig sabihin po nito dahil mataas ang potassium, naapektuhan po ang electrical activity ng puso, kaya nagkakaroon ng abnormal heart rhythm at mahinang pag-circulate ng blood ng bata. So for planning po, for our goals, we divided it into short-term and long-term. So for short-term goals po, within 4 hours of nursing care, the patient will maintain a stable cardiac rhythm, heart rate will be within normal limits for age, and the patient will show improved muscle strength and alertness. And while the caregiver will demonstrate understanding of the diet and long medications of the child. And within 8 hours naman po, serum potassium will return to normal range while the cardiac rhythm will remain stable. So now let's move on to interventions. For independent nursing interventions, we're going to monitor vital signs every 1 to 2 hours for early detection of cardiac problems. Monitor cardiac rhythm through ECG dahil pwede pong mag-cause ng arrhythmia ang hyperkalemia. And i-assess po natin ang muscle strength and activity tolerance ng bata para maiwasan ng injury. And also i-educate natin yung caregiver to avoid high potassium foods tulad po ng saging, oranges at kamatis. So monitor intake and output para makita kung may kidney problem po ang bata. So, encourage ang low potassium diet with small frequent meals to maintain nutrition safely. So, maintain safely precautions tulad po ng assistance sa paglakad. And i-observe po natin ang fatigue, tingling, or confusion. So, early signs po ito na nag-worse na ang condition ni patient. So, ensure natin yung IV access is patent para ready sa emergency treatment. So, for dependent nursing interventions naman po, we're going to administer medications such as sodium polystyrene, sulfonate, calcium gluconate, insulin with dextrose to lower potassium and protect the heart. So also we're going to administer IV fluid as prescribed to promote excretion of potassium, monitor laboratory values to evaluate treatment effectiveness. And also we're going to collaborate with pediatric nephrologists or cardiologists for specialized care. So, for collaborative interventions naman po, we're going to prepare for possible dialysis if needed. In severe cases lang po ito. And collaborate with dietitian for proper nutrition planning. And educate family on diet, medications, and warning signs to prevent reoccurrence of the disease. And importante po ito kasi ng hyperkalemia can become life-threatening if hindi agad na manage. So for evaluation naman po, for the short-term evaluation, after 4 hours of nursing care, the patient maintained heart rate within normal limits, the cardiac rhythm became stable as seen on ECG, the muscle strength and alertness improved, and the caregiver demonstrated understanding of care. So for the long-term evaluation naman po, after 8 hours, the serum potassium returned to normal range while the cardiac rhythm remained stable and the patient maintained improved strength and alertness.